Okay, so thank you very much, Kay, for the very nice introduction. And it is a real pleasure to have a chance to tell you a little bit about our research on spinal cord injury. So I have been working in the field of spinal cord injury for over 15 years, and our laboratory aims to understand reorganization after the injury in different neuronal pathways and use this information to develop, hopefully, better treatments. So it's very important to remember that in the United States, over 300,000 people live with a spinal cord injury or disability related to spinal cord injury. It's also important to remember that we still have over 17,000 new cases of spinal cord injury. And for the purpose of my presentation, we have to remember that over 60 or 70% of individuals with spinal cord injury develop spasticity. And this is one of the symptoms that I will try to review today, and how neurophysiology can help us to detect or perhaps detect the possibility of having spasticity in humans with spinal cord injury. And also it's important to remember that there is a group of patients that never develop spasticity, even though they have very severe spinal cord injury. So today, during my presentation, I'm going to address two primary questions. And the first one is how neurophysiology can help us to guide, first of all, our assessments in people with spinal cord injury. And in the second part of my presentation, how neurophysiology can help us also to guide or induce neuroplasticity in humans with spinal cord injury. So as you can see, we use neurophysiology as a main tool in our investigations in humans with spinal cord injury. So most injuries in humans, we have very good evidence by now that are anatomically incomplete. One of the large studies that showed that was published by Kakulas in 1984, who, using post-mortem analysis of spinal cord, showed that around 75% of individuals who have a diagnosis of a clinically motor complete spinal cord injury show evidence of some continuity of CNS tissue across the injured segments. There was a next study, a large study conducted at the Miami Project to Cure Paralysis by Richard Bungay in 1993, who demonstrated that using histological analysis at the epicenter of the lesion, that around 62% of the spinal cord specimens that were tested also show evidence of some continuity of CNS parenchyma. And there have been a number of electrophysiological studies showing that individuals have some residual connectivity below the level of the injury. And one of the studies that I always cite was published by Hunter Peckham in 2017, which showed that around 66% of individuals with a diagnosis of an AIS-AMB, this is a motor complete spinal cord injury, were able to produce some degree of electromyographic signals in muscles below the level of the injury. So this is an image of a healthy human spinal cord, and I just want to bring your attention to the location of the white matter tracts. This is the area in the dorsolateral region of the spinal cord, where the corticospinal tract of the big portion of the corticospinal tract is located in humans. This is the gray matter in the center. This is where all the descending connections or neurons coming from the brain or from the brainstem make connections with interneurons or motoneurons, and we can generate voluntary movement. In the subacute phase, soon after, or acute phase after spinal cord injury, if you see here, there is a large bleeding in the spinal cord, and this takes place largely within the center of the cord. This is the area that corresponds to the gray matter. Because this area is largely vascularized, therefore we lose immediately a large number of connections with motoneurons and interneurons from descending pathways. So what happened in the chronic phase is a little bit different. And we have been working for a number of years already with individuals with chronic spinal cord injury. So this is tissue from an individual who had a spinal cord injury for several years. This is the dorsal and ventral part of the spinal cord. So you can see that there is a formation of multiple cavities in the spinal cord. Most injuries are bilateral in humans, and both sides of the spinal cord are differentially affected. So it's not uncommon to have individuals who have asymmetries in terms of their deficits. And this is very important when we think about our electrophysiological assessments and also our clinical assessments, that there could be asymmetries in certain aspects of behavior or after of sensory and motor function. So I go back to spasticity because I'm going to try to link today the knowledge of neurophysiology and one of the most common symptoms that patients with spinal cord injury has, which is spasticity. And the concept of linking spasticity to these complete injuries comes from a number of years. And one of the first demonstrations was provided by Dmitry Heff in 1997, who proposed that the spasticity arises in patients with spinal cord injury who had evidence of residual and subclinical suprasegmental influence on spinal pathways. In other words, people who had these complete injuries. So this is one of the symptoms for which I think we can learn a lot from electrophysiology. And I'm going to show you some evidence of how physiology and spasticity in people with severe injuries might be very beneficial. So there was also another paper. This is a later paper that also showed more evidence about the relationship between motor complete injuries or a discomplete injury and spasticity, and link the presence of spasticity in this group of patients. So in this study, individuals were separated according to having a complete injury or an incomplete injury, and a number of measurements were taken in these patients that involve electrophysiology or some behavioral outcomes. So you can see here, this is voluntary control of movement. So individuals, this group of patients with motor complete injuries did not have voluntary control. And this group also did not have voluntary control. And these are individuals with incomplete injuries. However, one of the fundamental differences between these two groups is that there was a group of individuals, and actually a large majority of the individuals with complete injuries, who were able to respond in electromyographic signals detected below the level of the injury, even to a reinforcement maneuver, or even to the ability to voluntarily suppress either a tonic vibratory reflex or also a plantar reflex response in muscles below the level of the injury. So this group that responded to voluntary control or thoracic maneuvers or reinforcement maneuvers, and the response of that task we're seeing in electromyographic activity were classified as discomplete. Importantly, this group, the majority of this group, have spasticity. So complete and discomplete are artificial divisions superimposed upon what in reality might be a continuity of injury severity in terms of spinal cord injury. So what we decided to test these questions formally in 2019, and this work was conducted by one of my postdoctoral fellows, Dr. Sina Sangari, who tested spasticity and the relationship for the first time using electrophysiology with and activating descending motor pathways in humans with motor complete spinal cord injury. So Sina stimulated the leg representation of the primary motor cortex and recorded through EMG, in the quadriceps muscle, and we tested a group of individuals who had a diagnosis of a motor complete spinal cord injury. So individuals with AIS-A or AIS-B. And we also use structural MRI to try to analyze and make inferences about changes in the diameter of the spinal cord. So from those individuals, Cine tested 33 patients with motor complete paralysis. It is important to highlight that these people had chronic injuries and 60% of them show symptoms of spasticity. The other around 40% of patients did not have any symptoms of spasticity. So think about it. These patients do not have voluntary control below the level of the injury, but one group has spasticity and the other group has no spasticity. So what is different in terms of electrophysiology in these two different patients? So we found that the group that presented the spasticity have evidence of descending connectivity from the primary motor cortex. So I'm going to show you some representative examples. So in the y-axis here is the amplitude of the motor evoked potential in the quadriceps muscle, and this is normalized to the maximal motor response. And in the x-axis, these are just the patients that we tested, or some of the patients that we tested. In red are individuals who had a spasticity, and this is the degree of spasticity, the first number measured by the clinical exam. We also characterize spasticity using kinematics analysis, and this is the level of the injury. So we had people with spasticity with cervical injuries and also people who had thoracic injuries. So in all these individuals, the red circles show data of people with spasticity, we were able to evoke motor evoked potentials in this muscle that was located, motor neurons were located below the level of the injury. So you can see the latency is consistent with the corticospinal response, and responses are very small, but they were clearly present. In contrast, these are representative examples of patients who did not have spasticity in green. And you can see that in these individuals, also with different levels of injuries, either cervical injuries or thoracic injuries, in none of them we were able to evoke motor evoked potentials from primary motor cortex, suggesting that those individuals who had some residual descending connectivity had also spasticity. And this is the link that was proposed many years ago by Dimitri Hepik and others, suggesting that those individuals with these complete injuries have also the presence of spasticity. So to further test this hypothesis, we decided to also look at MRI signals. But before I go there, I want to show you the magnitude of these responses coming from primary motor cortex. So this is the data in control subjects. So size of motor evoked potential in the quadriceps muscle in a healthy control subject, individual without spinal cord injury, is around 10% of the maximal motor response. The group of patients that had a spasticity had very small responses. And we amplified this signal here, so you can see it's less than 1% of what we observe in a control subject. So it's really residual connectivity, but has the right latency, and responses are reproducible, but very, very small. And this is just data in people without the spasticity, showing no responses from primary motor cortex. So the second set of analysis that we did was MRI analysis. Spinal cord atrophy was measured in individuals with and without spasticity. And to avoid movement artifact, we went to the high cervical level. This is around C2 level. And we took axial slices, and we were able to analyze the area of the spinal cord and try to see if we could detect differences between those patients with and without spasticity. This is representative data from an individual with a modified Ashworth scale of 0, no spasticity, and this is an individual with severe spasticity. And you can see that the diameter of the area of the spinal cord seems a little bit larger in this individual with chronic injury who have spasticity. But when we did the quantification, this is a spinal cord area in millimeters squared. This is data from control subjects. These are both patients with spinal cord injury, but this group have spasticity and this group does not have spasticity. So the area of the spinal cord is a little bit more reduced in those who do not have spasticity. So then we were interested in where this difference is coming from. Is it coming from changes in the anterior posterior direction or in the left to right direction? So we measure the diameter of the spinal cord in the anterior posterior direction, and no differences were found between patients with and without spasticity. What was very interesting is that differences were found in the left to right direction. So individuals who had spasticity had larger areas in the left and right direction. And this is important because this is the area, as I showed you at the beginning, where descending motor tracts are related. So there was greater loss of diameter of the spinal cord from the left to right, in the left to right direction in those individuals who do not have spasticity. So when you put this information together, this means that people with spasticity had evidence of motor evoked potentials or descending connectivity, also have less loss of tissue in the spinal cord that is complementary to the physiological data. So then we decided to do a longer study and assess if this applies from proximal or distal muscles. And this paper was just published last year. And we look at a more proximal muscle as we did before, which is the quadriceps muscle. And then we also look at the soleus muscle, which also present spasticity. And this is a group of patients, and we characterize spasticity using a clinical exam. This is on the left and the right side. And this is a group of patients that presented spasticity bilaterally, and also in the more proximal muscle, which is the quadriceps, and in the soleus muscle, which is the more distal leg muscle. We observe a second group of patients with motor complete, the same diagnosis of motor complete spinal cord injury, who only presented spasticity in the more proximal leg muscle, which is the quadriceps, but we did not detect spasticity in a more distal leg muscle, which is the soleus muscle. And then finally, a third group of individuals who did not present the spasticity either in the quadriceps or even in the soleus muscle. So you can see this big spectrum of patients. They all have the same diagnosis of a motor complete paralysis. And then the question is how electrophysiology, how descending connectivity is behaving in the same group of individuals. So we tested motor evoked potentials evoked by either transcranial magnetic stimulation or electrical stimulation of the descending motor tracts in the high thoracic region. And this is what we observe in the first group. Those individuals, motor complete paralysis, who have spasticity, presented motor evoked potentials in the quadriceps muscle and also in the soleus muscle. And those two muscles have spasticity. The second group of patients presented only descending connectivity in the more proximal muscle, which is the quadriceps, which is the muscle that had spasticity, but no descending connectivity or no spasticity was detected in the more distal muscle. And then finally, the group that did not present the spasticity in either muscle did not show evidence of descending connectivity. And this is very important because it suggested that within the group of individuals with the same diagnosis, which is a motor complete paralysis, electrophysiology can help us to understand a gradient that in some extent might reflect the severity of the injury. So these are individuals with motor complete paralysis with less severe injuries because we are able to assess descending connectivity. And this is a group of individuals with very severe injuries that do not have spasticity and do not have evidence of descending connectivity. So this is what Dimitri Hepik at some point years ago suggested, that there is a continuum of injury severity, going from the same diagnosis, but within the same diagnosis, we have more and less severe injuries. And so motor complete spinal cord injury does not always mean the same. There is discontinuity in terms of the severity. So why do we think this is very important for rehabilitation? One of the areas where we think this information might be very helpful is for the stratification of participants in clinical trials. We propose that those individuals with evidence of spasticity and descending connectivity might have different outcomes compared with individuals with the same diagnosis of motor complete paralysis, but do not have spasticity or do not have descending connectivity. So this might be a symptom, together with the physiological outcome that might be considered for the stratification of clinical trials. It might be important also, and I'm going to show you a little bit of our new efforts to understand if this might help to stratify differentially the treatments of people with motor complete paralysis. For example, in inpatient rehabilitation, usually locomotor training, at least in the US, is usually offered for individuals with AIS-B, but no AIS-A. Okay, that means that individuals who have a little bit of sensory function, residual function, but no residual motor function, which are A's, do not receive that type of treatment. So what we're arguing that is that we should think about in terms of use, instead of using the clinical exam to make this big differences in terms of treatment options for patients, which you think perhaps in terms of some physiological outcomes to make these determinations. So you have connectivity or you don't have connectivity. So we started to test this hypothesis with our inpatients at Shirley Ryan Ability Lab. Thus, spasticity and connectivity can influence functional recovery, especially in those individuals who have very severe paralysis. And we are we just finalized the study, so we're working on the figures of the paper right now. So unfortunately, we couldn't put them all together, but I want to show you where we're going with these new results, because I think it's very important for neuro rehabilitation. Our hypothesis is that patients with spinal cord injury who have a spasticity might have better recovery compared with individuals who do not have a spasticity. And this is what the first data from 56 of our inpatients is suggesting. So we submitted, and we were fortunate to receive a grant from NIDLER, and we are testing this hypothesis in a multi-site trial throughout the United States. So our hypothesis there also, we have 5 sites. We are at Shirley Ryan Ability Lab. We are the leading site for this collaborative model. And our hypothesis is that patients with more severe spasticity, and we have different ways of quantifying spasticity using electrophysiology and also using kinematic analysis, will achieve better neurologic and functional recovery compared to those who have less spasticity. But keep in mind that this is for people with motor complete paralysis, AIS-A and AIS-B. So the sites that are participating in this collaborative initiative are Baylor, Scott, and White Spinal Cord Injury Model Systems. The Craig Neuro Rehabilitation and Research Hospital is also part, the Mayo Clinic, and also the University of Minnesota. So we recently were awarded this proposal, but it's important for the purpose of this presentation to highlight that this development started by neurophysiological funding. So neurophysiology can really help us to guide, we hope, our decisions, and we are proposing that neurophysiology might be a good biomarker to help us to understand which patients with motor complete injuries might have better recovery compared to others. So the second part of my presentation, as you can see, we love electrophysiology, is try to highlight how can we use neurophysiology also to guide neuroplasticity. So I just gave you one example of how neurophysiology can be beneficial or informative in order to detect certain symptoms in patients who have very severe paralysis, and hopefully that might help to guide our treatment decisions. So what about neuro rehabilitations in terms of an intervention or strategy? So there are a number of neurostimulation strategies, non-invasive, that are used today to enhance or try to restore voluntary control of movement. And I'm not going to mention all of them. You can stimulate the brain using different techniques. So you can go to the spinal cord using transcutaneous spinal cord stimulation. You can stimulate the muscle directly, the nerve directly, but usually all these strategies are stimulating the central nervous system using more general approaches. And they need to be combined with other strategies in order to facilitate voluntary outcome. So on the other side, we have a few approaches that target specific sites within the central nervous system. It's impossible probably to target one specific synapse, but within, if we compare these type of approaches with the approaches that I'm listing here, usually they are a little bit more focal. The approaches that are targeting, we're trying to target a specific sites within the central nervous system. So there are two approaches right now. There might be others, but the ones that we usually try to combine or we have a good interaction is with a group of Aiko Thompson and Jonathan Wolpa, who are using operant conditioning. And we are currently using pair associative stimulation. And those approaches are also need to be combined, in our experience, with other methodologies in order to facilitate recovery. So we are currently actually combining our pair associative stimulation with the medication. So I'm hoping that next time I can show you that data. We are in the mid part of that clinical trial that we're running at the moment. But I'm going to show you some of the data of how can we combine pair associative stimulation with exercise training to facilitate recovery in humans with spinal cord injury. So pair associative stimulation is based on the Heffian hypothesis. Okay, Donald Heff was a scientist that provided fundamental information about the organization of neurons and plasticity. So on his book, The Organization of Behavior, a neuropsychological theory that was published in 1949, he proposed that when an axon of cell A excites cell B, and repeatedly or persistently takes part in fighting it, some growth process or metabolic change takes place in one or in both cells in such a way that the efficiency of cell A is enhanced or is increased. Or in other words, cells that fire together also are wired together. So this is, we go back to electrophysiology again. So this is a cartoon that will show you how the principles of spike time independent plasticity work. This is just a cartoon showing you a neuron, and this is an action potential that will travel antidromically and orthodromically in both directions. And this is a synaptic input into the soma of this cartoon, this neuron. And we have good evidence that when a neuron makes a synaptic connection with a presynaptic neuron repeatedly and more persistently before the postsynaptic neuron fires, we can enhance synaptic plasticity. But actually, if we reverse the process more oftenly, we can suppress synaptic plasticity. So as you can think, there is a lot of background in animal experiments in vivo and in vitro for the principles of spike time independent plasticity. So how do we bring this protocol to a human? What has been the trajectory of spike time independent plasticity or pair associative stimulation in humans? So I just want to bring you first here in 1985, when the first paper that used transcranial magnetic stimulation in humans was published. And this is very important because for us to use pair associative stimulation, one of the techniques to elicit descending bolus is that we use is transcranial magnetic stimulation. So if you think about the evolution of pair associative stimulation, the first paper that was published in humans using pair associative stimulation target target the primary motor cortex, not the spinal cord. And this was published by Katia Stefan and others in 2000. And they stimulated a peripheral nerve, I think it was the median nerve, and they target the sensory motor cortex, the hand representation of the sensory motor cortex. And what they observed, that after pairing these pulses in such a way that they arrive at a presynaptic compared to a postsynaptic terminal at the level of the motor cortex, they were able to potentiate the amplitude of corticospinal responses. So then in 2003, there was evidence that using this repeated pair of pulses, could have an influence on behavior. Thus, induction of plasticity change motor cortex, improve leg function to a little extent in individuals or in patients with stroke. So this was the first indication also that pair-associative stimulation could have a functional impact in motor behavior. Then in 2009, and I want to highlight here, Janet Taylor showed that this principle can be used also and target the spinal cord. So she targets motor neurons that control the biceps brachii in healthy humans. And instead of targeting the primary motor cortex, as you can see here, the target was the spinal cord. This was in 2009. And in 2012, we published the first protocol using this proof of principle studies in humans with spinal cord injury. So how does it work? So we use electrophysiology in order to stimulate and to determine the timing of when do we activate descending volleys and when make estimations of when these volleys can arrive to the spinal cord. So in the past, we use only transcranial magnetic stimulation, either over the hand representation of the motor cortex, it could be on the left side, on the right side, also in the middle part of the brain to activate corticospinal neurons that project to leg muscles. Today, what we're doing today, we also have, the technique has evolved quite dramatically, and we are also activating corticospinal neurons directly through the spinal cord to use this pair-associative stimulation. And we think that might have several advantages in the way in which we activate descending volleys. And I'm going to show you some of the data. So this is one of the sources. So this type of stimulation either is in the primary motor cortex or directly over the spinal cord, activate descending volleys that go down to the spinal cord and are aiming to depolarize motor neurons. And then we combine this with peripheral nerve stimulation. So we activate different peripheral nerves, and these volleys elicit antidromic volleys that go back to the spinal cord. And we play a little bit based on central conduction time and peripheral conduction time, based on electrophysiology, with the timing at which this interaction might take place. So we have conducted a series of proof of principle studies to understand at the beginning how this plasticity could work, and are there differences between the arm and the leg. So in the first study, as I mentioned before, in 2012, we stimulated the hand representation of the motor cortex, and based on electrophysiology, we determined the time when we stimulate also the ulnar nerve. And we show that approximately around 100 pair of pulses every 10 seconds, this was done completely at rest, facilitated the size of corticospinal responses. But what was very interesting is that also individuals became a little bit faster when they have to perform the 9-hole peg test. So that suggested earlier on that this type of plasticity could be relevant or functionally relevant for people with spinal cord injury. But this was only 17 minutes of stimulation and a single session. And in this paper, patients with spinal cord injury were randomized to 3 different sessions where we aim to increase or decrease corticospinal excitability. So then we try to optimize the protocol, and especially for people who have very severe paralysis. So we ask the question, can we increase or decrease the threshold of spinal motor neurons so we can have better chances of eliciting this plasticity? So you can see here, we use the pair pulses, the same as here, but now during small levels of voluntary activity. So every time that individuals receive the pair pulses, they have to perform a little bit of level of voluntary activity. And this was very important because this, for two reasons. First, because the patient performed voluntary activity, motor neurons were already active, and we have more descending volleys going to the spinal cord. So our hypothesis was that this was enabled the possibility of facilitate our ability to induce this type of plasticity. So what was very important that then we demonstrated that the number of responders increased compared to the previous publication. And also because here we tested individuals with more severe injuries than what we did before. So that was another important part in the optimization of the protocol, suggesting that if you're going to use this plasticity, it's better to have individuals to perform tonic level of background EMG activity. Then the question is, okay, we can induce this plasticity or this potentiation in corticospinal output in upper limb muscles. Janet Taylor showed it in the biceps, we show it in the hand. What about the leg muscles? We know and understand, and I know Kay is working also with the leg, stimulating the leg representation and targeting leg muscles. So we conducted the first study where we use this pair associative stimulation targeting the tibialis anterior muscle. There were some fundamental differences compared to what we observed before in the arm. The first one is that we needed larger number of pair pulses to elicit these changes in the leg representation of the motor, targeting the leg representation of the motor cortex compared to what we observed before in the arm. So we needed 180 pulses, okay? A reason could be that leg corticospinal neurons or corticospinal excitability, the threshold for leg muscles for eliciting a response is higher. There could be several reasons, but that was a main difference, that we needed a larger number of pair pulses. And also there was some differences in terms of the timing. Okay, and you can go more in detail to the paper, but at the end, we observed that we could still facilitate corticospinal transmission and also suppress corticospinal transmission regardless of the differences that are present in the arm, in the leg compared to the arm representation of the motor cortex. So it was feasible to elicit this plasticity. So then we decided to conduct our first randomized placebo-controlled trial. We published this in 2020, and the leader author of that trial was Dr. Han-Jin Zhou, who is a postdoctoral fellow working with me. What we did in this study was to try to include individuals with different severities and different type of injuries. So included individuals with more or a little bit of residual control in the hands. And if they have that residual control, this was our target. If they were very severely paralyzed here, we target more proximal arm muscles. So individuals were randomized to 3 different groups, the groups that received exercise with pair associative stimulation or exercise with sham pair associative stimulation, and a third separate group received only the stimulation for 10 consecutive sessions. But what we observe, if you look at in terms of the primary behavioral outcomes, which was the grasp test and the 10-meter walk test, both groups, just with exercise, improve in terms of their ability to perform these behavioral outcomes. The main difference that we observe in this group is that individuals who received the real stimulation were able to maintain the changes for a longer period of time. So this is the changes were maintained around 6 months after the intervention. And this is electrophysiology in terms of changes in corticospinal excitability and also in terms of electromyographic activity. So then after we were able to observe these changes, it was clear that we needed much more to further recovery. So we needed to keep optimizing the protocol. So we moved from a single muscle or targeting a single muscle, more or less, with exercise rehabilitation for 10 sessions to target multiple muscles at the same time. And this study is under review at the moment. We were able to finalize or finish data collection in several individuals and that participated in 40 sessions of what we call multi-site pair-associative stimulation. So we stimulated these 8 different sites, peripheral nerves at these 8 different sites, and we targeted the left and right primary motor cortex to induce this spike time independent plasticity to upper limb muscles. And for the leg, because we don't have room here for another coil to stimulate the leg corticospinal neurons, we went to the high thoracic region. So you can see that is a very comprehensive study, but what we have seen with these 40 sessions and this multi-site plasticity in terms of recovery of function is greater than what we observed when we targeted a single muscle, even though combined with rehabilitation. So it's 40 sessions and we took multiple measurements. So I'm just going to show you some of the videos. And this is Dory. Dory was one of the first participants, and her main goal, she had a spinal cord injury for 22 years, a cervical injury, and she wanted to jump. So this is Dory before these sessions.
Sweet, huh? That was more than yesterday. Nice.
So unfortunately, I'm not going to have time to show you where we are now. This was the most recent results that we just submitted for publication. This is Phil, and after 40 sessions with multi-site stimulation, he improved trunk control, his ability to walk. This is another individual after 40 sessions with cervical injuries. You can see that he still needs body weight support, but he can ambulate much more and with much more control than what happened after. Before the stimulation. So what we're doing now also is we never took individuals who had very, very severe paralysis and who were not able to initiate one step on their own, even though they have to use an assistive device. So this is Amber, and this is Amber before the sessions, and she needed the assistance of 2 therapists to be able to advance the legs, and this is Amber after only 40 sessions. So we still have a long way to go with the protocol, but the message here is protocol optimization is extremely important to get where we are. And next time, hopefully I can show you where we are, because the protocol now, we're not only doing these 40 sessions with multi-site stimulation, but we're also using the medication to facilitate recovery. So neurophysiology, how neurophysiology can guide our assessments. I think I show you an example in terms of spasticity. Keep in mind those individuals who cannot move below the level of the injury, but have a spasticity. Neurophysiology has provided us a tool to detect that there is some descending connectivity, and how neurophysiology can help us to induce plasticity with our pair-associative stimulation. Neurophysiology is fundamental in order to understand that plasticity. So I just want to thank everyone in our group who is working on these experiments and help us to understand reorganization after spinal cord injury, and especially also our funding agencies who have provided support for our work. Thank you very much.
Well, thank you so much, Monica. It's very exciting talk series of evidences. Dr. Feng, you have a question?
Sorry. Actually, I just please just give the hand clap. It's not a question, just hand clap for Monica give this wonderful talk. This is really inspirational and use the, so I see a lot of clap comes along. I think this is one of the very successful research, translational research to see the wonderful news to the spinal cord injury patient. Thank you, Monica, for this wonderful work.
Thank you very much. Yes, for having me here.
Yep, thanks so much. So I see Alash is raising hand. Oh, sorry. Next, Molly.
That was just a clap.
I think Molly has a hand, right? Yeah.
Yeah.
Monica, excellent presentation, very nicely put together.
Thank you. Thank you.
I wanted to ask probably two questions, if I might, but one is related to the latter part of your talk. Having put very early on, years ago, because you can see it's years ago, individuals on a bicycle, lower extremity, bicycling, doing, at that time, we were just using MEPs to see what in fact was happening to the lower extremities. Okay. But what became important to me was that your comment about stimulating multiple multiple areas at the same time to get that particular function. And so it raises the question for me is that your paradigm of looking at how that lower extremities are moving is related to your locomotory, treadmill kind of paradigms. Have you tried any paradigms where you work the program of moving the muscle cyclically,
yes,
like you would in locomotion in sitting, and then add the postural component to it?
Yes, that's a really good question. So we, our protocol, the problem with, because, we all think that you have to stimulate in an activity dependent manner, exactly as you said, Molly, that can give us better outcomes. So the problem with pair-associative stimulation is that we need to use strong intensities to stimulate the peripheral nerve because we want to activate the majority or most of the motor neurons to get antidromic volleys going to the spinal cord. Okay. So it's very important to have for this plasticity to be more successful, to have a strong stimulation. So we have done it during cycling. Okay, and I can show you videos. Patients, when they receive, because it's very strong stimuli. So when we stimulate peripheral nerve, especially the femoral nerve, common peroneal nerve, posterior tibial nerve, with very strong intensities, they can still cycle, but there is a little bit of interruption of the movement. So it's a very good point. I think, there is we have preliminary data and we thought we were the first ones to start this experiment, but actually there is another publication this year that Kay might be interested. They show that they can induce the effect, but by reducing the intensity, but seems to be a little bit less effective. If you decrease the peripheral nerve stimulation, you let more afferent input to take a role. So it might be for this type of plasticity not as effective. But this is why I think it's very important maybe to do this during standing position or during muscle activation, because then you break the activity component. Yes, so I totally agree. It's just the limitations of the type of protocol that we're doing, that we're using generalized voluntary activation. But even with that, maybe it will be more effective to do it in a standing, which is a more postural, it's a more activity. It's not moving dynamically, but at least it's related to some function. Yes. Yeah, very good point. Very, very good question. Yeah. So I think we should continue to explore more. Unfortunately, right now we started with 40 sessions. We have patients who have done 120 sessions. And maybe next time I can show you some recordings. We have muscles with 0 EMG activity after 40 sessions, 80 sessions, and then 120, you see a burst. So it's so interesting how you can recover. So in a study, if you measure only one muscle, you might not see that, or it might take you longer. So I think all of these considerations are very important to understand recovery. Okay, because we might be missing in the design of the clinical trial is so important. It's so important in that first randomized clinical trial. If our outcome was only behavior, our interpretation will be that placebo and real stimulation do the same. But then we had physiology and follow-ups, and then we notice the difference. So it's equally important. I'm wondering how many protocols we think they're not working because we're not measuring properly. It's equally important. I cannot stress more in the need of understanding the measurement, standardization, equally important as having a good protocol. Yeah.
And then I had one other quick question, okay, if I might, because there may be others. And that is the difficulty is always where in the terms of the whole recovery profile is the individual. And so my question is related, do you have any evidence from looking at the multiple studies that early on is more important than, so many years out, and the timing of that piece versus how atrophied the muscle already is there any potential for stimulating the muscle to just try and build muscle?
Absolutely. Great question. Again, so I think right now our inclusion criteria is that individuals need to be able to have descending connectivity. Okay, so we have that descending connection. Regardless if they are more paralyzed or less paralyzed, so that connectivity is essential. If we look at the data for chronic individuals, we see similar improvements in somebody who have had a spinal cord injury for 1 year or for 20 years. Okay?
Right.
So the chronic it doesn't matter really, for at least this is what our data reveals.
Okay.
We have done a couple of subacute patients and we see recovery, but we haven't published that. And because there is a spontaneous recovery also in the subacute phase, it's very important how to randomize and how to run that trial. Yes, to make sure that this is over or superior to the effect of a spontaneous recovery. So we don't know. And where we are going now is also to the acute phase. We want to start even earlier. So that's the future. I can tell you in a few words what we are planning to do and what we're doing, but because we don't understand yet. Yes, those are questions that are missing and I think can help us a lot. But in the chronic phase, we have sufficient data to make the inference that 20 or 1 year or 10 years, we don't see differences. Yes.
Okay, thank you.
Right, thank you. I see Hope is raising hand.
Thank you, Dr. Masseni. Thank you for a great presentation, Dr. Perez. It's so nice to read your research and then actually get to attend a presentation from you. So that was great. And my question is, considering the evidence you presented, differentiating between proximal, distal, and other spasticity, should we consider revising the AISH classifications? Do you think there should be a different system altogether incorporating gradients, or maybe you want to stick with the old AISH classification system? I don't know.
Yeah, I think that's a very good point. I think we should complement our clinical assessments with other assessments. I think a patient, if you tell me I have a patient with ASIA A or B, it could be in that gradient that it has been described, but now physiology allows us to maybe visualize the gradient, because until we have tissue or other methods, it's very difficult to visualize the gradient of connectivity. So it's extremely important to consider that gradient, because maybe that patient for a clinical trial that might have better possibility of recovery. I always ask Susie or Gregoire, Are those patients who receive the epidural, do they have a spasticity? Are those motor complete really spastic individuals or not? Because there is a huge difference, and we have to pay attention also to the muscles that we're testing, because we are very intrigued, and there's some fellows in the lab looking at this gradient also, because it makes sense. If you have an injury to the spinal cord, not everything is severely impaired at the same, at the same level. Usually injuries affect more than one segment of the spinal cord. So it's a trauma. So it's very obvious that pathways and different connections will not end at the same level. You have some connectivity going to more lower motor neurons and up. There is a level where you can have this type of findings. And that is important for our assessments. So because what happens if you test the soleus muscle and not the quadriceps, So we always think, oh, this patient is spastic. Yeah, okay, but we don't think that there could be muscles without the spasticity in the same patient, isn't it? We always do these generalized assessments. So I think physiology have tell us to individualize some of our assessments and also think about bilateral improvements or bilateral changes. Yes. So I think, I don't know if we should change the ACI score, but I think we need to complement. We need to think about and be aware of these findings also, because that guide us, help us to move forward. Yeah.
Great. Okay, thank you. I see Ken is a rising hand, but it's 1 o'clock. Can I move on to the small group discussion so that we can ask more, have more discussion? Would that be okay, Ken? Yeah, so thank you for everyone. We're going to finish this lecture at this moment, but we're going to move on to the small group discussion. But before finishing up, let me make one announcement from Jousse lecture series. Jousse lecture series at the KITE Research Institute, and we have next one is coming on April 14th. And by a Canadian network of individuals interested in spinal cord stimulation. Dalton Wolf, Caroline O'Connell, Stephanie Morocco will present the lecture. Thank you so much for everyone. All right, so the lecture itself is done here. Thank you for everyone participating. For people who have more questions, please stay here. We have a small group discussion. Thank you.